When they asked me yesterday if I would introduce Dr. Allen, I said, well, yeah, that'd be a piece of cake because she really needs no introduction at all, being the director of this symposium. But as I thought a little bit more about it, I think this is a good time to brag on Dr. Allen a little bit. So Dr. Allen grew up in Enid, Oklahoma, and then obtained her medical degree from Loma Linda, and then an internal medicine residency in Los Angeles. And at that point, she returned to Oklahoma for a derm residency and has been in the Department of Dermatology since that time. But to brag on her a bit, she's now the vice chairman of the Department of Dermatology. She has been the long-term program director for the residency program. She's the chair of the College of Medicine Diversity Alliance Task Force. And to give you an even better idea of how much we depend upon her, she stepped in to give this talk yesterday when one of our faculty members was unable to attend because of a family emergency. So without any further ado, I would like to say how important she is to the department. And she's going to give us a great lesson on diversity in medicine and how it affects us in our everyday lives.
Thank you so much, Dr. Stasko. I really appreciate that. And this subject that we are going to discuss today is near and dear to my heart, and it's entitled, Do You Really See Me? Exploring diversity and facing our biases in healthcare. I have no relevant financial relationships or affiliations with commercial interests to disclose. So the professional gaps, one of them in particular, we're going to look at actual, which healthcare professionals and medical learners do not fully understand the barriers that prevent minorities and underserved communities from receiving health equity. And so what is our ideal utopia? That healthcare professionals and medical learners will gain a better understanding of the barriers that prevent minorities and underserved communities from receiving health equity. So upon completion of this session, participants will improve their competence and performance by being able to define diversity, equity, and inclusion. And you will hear me call it DEI. If you're not familiar with that term, that is what we call it when we were looking at all three of those items together. And we will describe the impact of bias in the healthcare setting. We'll discuss health disparities and social determinants of health. So first of all, we must define diversity. What is it? If I were in a classroom or in a small roundtable discussion, I would take just comments from the room, but it is a workforce, especially when you're thinking about a healthcare system setting. It's a workforce made up of individuals with a wide range of characteristics and experiences. It includes race, ethnicity, gender, age, religion, physical ability, socioeconomic background, and sexual orientation. Diversity, what is the outcome? It can increase productivity. Why do we need it? Productivity, it increases creativity, language skills, cultural competence, and reputation of a specialty. Here at OU, yes, we have a diversity statement, and many academic institutions do, and ours states that it will advance a diverse, equitable, and inclusive university community, embracing each person's unique contributions, background, and perspectives. As you know, OU not only includes the undergraduate campus of Norman, but also OU Tulsa, in addition to the Oklahoma City Health Sciences Center. And so this statement goes for all 3 campuses. Diversity is paying attention particular to the needs of historically marginalized populations and is vital to the pursuit of excellence. So let's look at the term equity. And many people get this confused with equality, but there is a difference. Equity is providing various levels of support and assistance depending on specific needs or abilities. It's basically giving a person what they need to succeed. That may not be the same thing for each person. It's individualized. And so this thought of equity guarantees fair treatment, access, opportunity, and advancement for all. No matter where a person starts, they are getting what they need to succeed. It's to identify and eliminate barriers. And the principle of equity acknowledges that there are historically underserved and underrepresented populations, and that fairness regarding these unbalanced conditions is needed. And in the provision of effective opportunities to all groups. And so many of you have seen this caption, this is illustration, just comparing and contrasting what equality is. Now, equality is what you see on the left side, where you have given each person the same box, the same height, but is this individualized? Is it meeting the needs of every person? Can everyone see over the barrier of the fence? Let's contrast that with equity, where it is fairness in every situation, giving each person what they need to succeed. So if someone comes from a family that has generational wealth and has the ability to pay full price for medical school, and yet you have others with the same abilities of academics, but unable because of their circumstances, their socioeconomic circumstances, may not be able to even attend because of the financial strain. You give them what they need to succeed. Another way of looking at it, here you have everyone with a bicycle. Equality, everyone has the same bicycle. But looking at each individual at the top, is it meeting their needs? Let's look at the bottom, where equity is giving a person the tools that they need to succeed and progress and be productive and to be part of a team that is diverse in many ways. And then the last piece of DEI is bringing traditionally excluded individuals and or groups into processes, activities, and decision policy making in a way that shares power and ensures equal access to opportunities and research, inclusion. And so I like this saying from the diversity advocate, Verna Myers, and she's the one that coined the phrase, diversity is being invited to the party, but inclusion is being asked to dance. Hopefully you get that, because in a workforce or in an academic institution, there may be some representation, but are those people invited to the table? They may be in the room, but is their voice heard? And so that active piece of inclusion and engagement is extremely important. So let's understand the differences by looking at some dots and circles. And so we're going to match it up here. In diagram A, what do you see that's different? We have green dots only in the center of the circle, inside the circle, all together. But, and you know, you can put it in terms of people. And then everyone else that's different is standing outside of the circle. They are not part of the inside clique. So looking at the different terminologies here, being able to use them correctly, what would you say this is? Exclusion. So this represents a visual of exclusion when those that are different are standing outside of the conversation. They are not even, you know, taking part. They are not engaged. They have been excluded. So let's look at C, inclusion. This would be the ideal, and actually looks like from A to C, they took out a few red and blue and yellow dots. They should put more back in, but the gist is everyone is included. Everyone is part of the conversation. They are inside of the circle, intermingling, mixing, but also their voice is heard. Let's look at B down here, where you've got a circle of majority green, and then you have a smaller circle within the big circle of diverse dots or people. What does that represent? They're inside the room, but yet not part of the conversation. They haven't been asked to dance. They've been integrated, but yet not completely included. And so another term would be desegregation. And this took back place in the 60s, where, as you know, the public high schools and public school systems were desegregated, or integration happened. And just as a personal example, Dr. Stasko stated that I was from Enid, Oklahoma. I was born and raised, which is about an hour and some change north of Oklahoma City. And the African-American community was literally across the railroad tracks, as many are in many cities and states. And so in that community, they had their own public or high school, the Booker T. Washington High School. They had their own elementary, Carver, Washington, or the Carver Elementary School. And so they were next door to each other. My mother was a teacher at the Carver Elementary School. She was the very first African-American teacher in Enid, Oklahoma, that was selected to integrate into the Enid Public High School. And in that time, this is before I was born, you could cut the the tension with the knife, as she would say. The prejudice, rhetoric, as well as behaviors from her white colleagues as well as students, she reminisced about. And it was a tough time, but I will say that because of her personality and love for people of all colors, of all walks of life, you know, those barriers started to melt away. And within her career, she became the head librarian of one of the junior high schools. She went from the public high school to a junior high school and being the head librarian. And her picture now sits within the Oliver Hodge building, which is one of the state capitol education buildings, as she was the first African-American teacher to be selected in the Educators Hall of Fame of Oklahoma because of her advocacy and reach back to the African-American community. Let's look at D. When you have a large circle of similar dots in people and a system that's working without or outside of this circle, that is what true segregation is. That is what separate but equal meant, especially in our educational system, where the best of tools and education and school buildings and books were afforded to non-Black schools, and the African-American schools basically were of a second class offering. And so that is true segregation, separate but equal. So remember those images and ask yourself, in the environments and settings that you are in, whether it's at work, in an academic setting, where are you today? So what compromises the achievement of DEI in healthcare? Bias. Do you really see me? Do you see your patients? Do you see those students? And are we seen in research? And so we're going to discuss those areas, but also define what bias means. It's a preference or a tendency to be in favor or against a particular perspective or ideology, object, individual, or group, and it interferes with the ability to be impartial, unprejudiced, or objective. And so, yes, it can exist towards many different things such as race and gender and physical disabilities. Maybe it's weight, sexual orientation, religion, and it can exist in a person, group, or systemic institution. And so it's important to understand that, because bias is not only verbal, but nonverbal behaviors. And that can affect a group of people or an individual. So it is different from stereotypes in that stereotype is a preconceived idea that is attributed to certain characteristics to all members of a class or set. So there is a little difference, but they're very similar. And so there's many types of subclasses of biases, but we're going to talk about just the very two main types. One is unconscious bias, and many people liken that or use it interchangeably with implicit bias. And there is conscious bias or explicit bias. Unconscious bias is that automatic, it's unintentional. outside of our awareness. We're not aware that we're even doing or saying something that may be harmful or hurtful to a person. It's outside of our control, but it affects judgments, your decisions and behaviors. And it's a learned stereotypes for most, and it alters our behaviors and interactions with people. When it's a conscious or explicit, that means you know you're doing it, but you do it anyway. It's very clear. The person knows their feelings and attitudes, and their related behaviors and how they conduct themselves. It's conscious. This is on a conscious level. And so it is overt negative behavior. It can be physical or verbal harassment, or even through subtle means, like I'm just going to exclude this person altogether. And many people under the unconscious bias, they're now starting to split out implicit bias, and they say that it is more of a type of bias in between unconscious and fully conscious. There is a level of awareness that a person starting to understand that maybe they said something that was offensive, or had a microaggression. So implicit bias, with all of the things that are happening within our society today, on media and in our classrooms of education surrounding bias, it's very hard at this point, very difficult to not know and have some sort of awareness of bias. And so that is where implicit bias is now slowly starting to tease out of that definition. So microaggressions, these are those little mini micro insults, everyday biases. And it's subtle actions and behaviors, both verbal and nonverbal. It can be conscious or unconscious, and it's directed to a member of a marginalized group. And it can be very derogatory and have a very harmful effect. And this term, microaggressions, was introduced by Dr. Chester Pierce in the 1970s. He was a psychiatrist at Harvard University. And so you will hear that term even more so today. And so we're just going to talk a little bit about biases in health professions education. And this includes medical school, nursing school, any of the health profession fields. And I'm going to show somewhat of a video, and I'm going to start the video, and let me make sure that everybody can see it very, very quickly here. Hold on. I must share my screen with that on it. Okay. Everyone see that? All right, here we go.
Dr. Allen, there's no sound.
Oh, hold on. Hold on. Hold on. Let me make sure that I have everything unmuted. Okay. Tell me if you hear anything now.
I do not hear it.
Hold on. What? That's not what I wanted. Hold on. Let me just get out of that very quickly.
We can hear it barely, Dr. Allen. There's something coming through.
Okay. Can you hear anything? Wait, well, I'm going to go on because I might be able to get it later. I'll go back. But basically, it was looking at students at University of North Texas, and they were giving their own experiences. I'm going to try it at the end a little bit later and see if we can get it going again. But I'm going to go ahead and keep going. But it basically told their experiences of what they had within the classroom. So in the classroom, what are some of the things that people can be faced with? So as a educator, what's happening out on their level? So what if the educator is talking to students differently based on their race, ethnicity, sexual orientation, religion, and physical disabilities? You know, that is a bias. They may even discount someone in the room based on certain characteristics. And so also singling out learners to speak on behalf of entire race. What do you think, you know, if they're talking about, you know, an African-American issue, they want, you know, that lone African-American student to be the spokesperson for that race. And so that is a type of bias. LGBTQ community, or singling out a religion or physical disability. All of those are things that, you know, can definitely harm and hurt our students. Maybe disregarding learners based on gender, race, or ethnicity. Attributing health disparities to race, ethnicity, without discussing social determinants of health and health behaviors. So in other words, discussing maybe a medical condition that is seemingly more prominent in maybe African Americans, hypertension, heart disease, all of these things, but just stopping at the race factor. And instead of going back and saying, why do they have such higher rates, and not discussing the social determinants of health and health behaviors. Maybe it's the diet, maybe it's finances, and they live in a food desert and do not have access to healthy options. There's so many factors that have to be discussed, but if you don't, and you just stop at race, you are implanting that within students and future health professionals. So on an individual learner base level, what does that cause? How does that look like to them on their side? Well, we know that underrepresented in medicine students are at greater risk of poor personal well-being, increased stress, depression, and anxiety. URMs report race, ethnicity adversely affects their medical school experience. And they also raise concerns about racism and bias in their own test scores, their evaluations and assessments by faculty who have less than adequate training in cultural competence and bias. And so there's another YouTube, but I'm afraid that it may not play, so I'm going to keep moving and we'll try to get to those at the end. It's important to know also that the AAMC, the Association of American Medical Colleges, partnered together with the Ohio State University. They have the Kirwan Institute for the Study of Race and Ethnicity. And they, in 2014, convened a forum that looked at diversity and inclusion, unconscious bias, and academic medicine. And they actually looked at 7 areas. These were experts in unconscious bias, whether they were researchers or professors in different academic institutions. And they looked at medical school admissions, undergraduate medical education, resident recruitment, resident or faculty recruitment, faculty mentoring, as well as faculty advancement, promotion, and tenure, and patient care. And what were the outcomes? Basically, they recommended that engaged leadership can create a culture of safety and inclusion, mitigate bias through education and training, also mitigate bias in committee structures and operations, as well as individuals can take their personal steps to mitigate bias by going out and getting to know others who are outside a culture outside of your own. Mitigate bias in admissions and recruitment strategies. And so it's important to understand that issue. So let's look at, we've looked at in health profession educations, let's see how biases can affect patient care. We know that it leads to false assumptions. There's negative outcomes, especially in our minority groups, and it can be life or death decisions. It leads to health disparities, and we'll talk about that. And there's non-medical factors that influence decision-making. Maybe it's the way they're dressed. All of these factors, age, race, ethnicity, gender, sexual identity, religion, disability. Maybe it's their insurance status, or maybe it's because they came from a bad neighborhood or a setting of a free clinic that makes a person biased. And so there are studies that show that with regards to physicians, white male physicians are less likely to prescribe pain medicine to Black patients than to white patients. That's been actually documented in many studies. This one, based on racial bias and pain assessment and treatment recommendations and false beliefs about biological differences between Blacks and whites. This was a study at University of Virginia where they actually surveyed lay people, actually about 121 adults, and these were, and non-white people were excluded, and those who could not speak English. So these were 121 English-speaking, non-Black or other ethnicities other than white. And so they rated pain across 18 scenarios and then randomly assessed the rate of pain of gender match between white and Black people. And they also looked at their fault and their beliefs that Black people's skin is thicker than white people's skin. And basically in this first phase of the study, it revealed that participants who more strongly endorsed false beliefs and biologic differences reported lower pain ratings for a Black versus white. And then they did this same study and even took it to medical students from first year all the way to fourth year. And there were over 222 that actually completed the online assessments. And it basically showed that half of that sample of white medical students and residents endorsed these same beliefs, rating that Black versus white patients' pain is lower and made less accurate treatment recommendations. So this is showing that individuals with at least some medical training hold and may even use false beliefs about biological differences between Black and whites to inform their medical decision-making, and contributes to racial disparities in pain assessment and treatment. In JAMA Pediatrics, similar outcome where they looked at children with appendicitis who presented to the ED, and they had about a million children. They did a cross-sectional study of patients 21 years and older with appendicitis. And so this National Hospital Ambulatory Medical Care Survey over a 7-year period, they looked at those charts and what types of pain medicine, if any, were given, and they calculated the frequency of both opioid and non-opioid administration. And 56.9% of those who presented with appendicitis received an analgesia of any type, but this is the kicker here. 41.3% of those who actually, 43% or 41.3 received opioids, but of that 41.3%, 20% or 21% were Black patients, and double the percentage of white patients. So this is towards the belief that Black children are less likely to receive any pain medicine for moderate pain and less likely to receive opioids for severe pain, suggesting that there is a different threshold for treatment based on race. So also, it's been reported that doctors assume Black patients of low socioeconomic status are less intelligent, more likely to engage in risky behaviors, less likely to adhere to medical advice. So with these types of beliefs, you can just imagine how their quality of treatment will be. Just in general, women presenting with cardiac heart disease symptoms are less likely to receive diagnoses and referral and treatment than men. And this is due to misdiagnosis of attributing to stress and anxiety. So many women may not present with the classical chest, heart, pain. It's going to be maybe acid reflux type symptoms. It can be acute sweating. It could be abdominal pain. And many times their symptoms are brushed off and they are misdiagnosed with these symptoms. Let's look at biases in research. So in research, there are many things that we can look at that can be biased. One of them, gender, race, and ethnicity inequalities in science. So you may not see as many women in the laboratory, in the basic sciences. Also, lack of the underrepresented minorities in medicine, such as African American, Hispanic, Native American, Hawaiian, Pacific Islanders, Puerto Ricans. But you see a very multicultural international research working environment, many speaking in native tongue. And so many times they have formed, they can form their own little environment and microcosm. And for those that may be underrepresented that are in labs may feel excluded. And so that can also be something that is seen. But we also know that just research subjects, there is lack of diversity in research studies. And we know that whoever is researching the makeup of our researchers, if they are looking at their own interests, what they're interested in. And so that's the type of production of literary proceedings that are going to be made. And so if you do not have researchers that represent their backgrounds in research, there's going to be a lack of that type of research coming out. And so there is disparity in the areas of research that are truly needed. And there's a reticence of people of color to participate in research, as we know, due to past scientific traumas. And we're going to talk about some of those traumas. Everybody, I think, wants to talk about the syphilis study. Everybody knows syphilis study. And the thing is, it was a study in Tuskegee, Alabama, that spanned 40 years. And it was a governmental experiment where they asked African-American men with syphilis infection, asking them to enroll in this study, or be a part of it, I should say, and state that they were going to get treated. And that was the deception of a lifetime, I should say. And there were over 400 Black men with syphilis. They were deliberately left untreated so doctors could study the disease, whether it was neuro or cardiac issues that developed. They were just looking at the natural progression of syphilis to the demise of these Black men. And so it was only by the exposure of the New York Times in 1972 that the study stopped. They exposed this atrocity. And so from that 1979 Belmont report, they established the Office of Human Research Protections and the institution review boards, which we all have on our academic medical institutions. It is for the protection of human subjects, and we know that there are those are certain protected groups that must be considered before even allowing them to be in studies, such as pregnant women, children, prisoners, minority groups. There's several disabilities that, and so there are protections in place to help prevent this from happening. But this is in modern times, you know, just in 1972 that it was stopped. And so there are still Black men of these studies that are still alive today that will tell their story. Another legacy of mistrust with people of color in research. Many of you know Henrietta Lacks. She was only 31 years old, 1951, had advanced cervical cancer, and she went to Johns Hopkins, got treated with radium, but unfortunately she died. During the time of treatment, her cancer cells were saved for research without consent. And so, interestingly enough, it was the only cells that they had retrieved. Not that she was ever the first that they received retrieved without consent, but the first immortal cell line. They lived in their environment where they could study several diseases using her cell lines. And so it's been used for cloning, develop polio vaccines, study of HIV, herpes, Parkinson's disease, and other cancers. And her cells are named after her first and last portions of her name, HeLa cells. And this is the only cell line that has outlived an actual person. And so Johns Hopkins did apologize and wanted to make it right with the family of Henrietta Lacks. And in that, the family granted Johns Hopkins to continue their research, knowing the vast impact on medical interventions and discoveries that it has made. Another legacy of mistrust, James Marion Sims, who is considered the father of modern gynecology. He is the one in Alabama that performed controversial experimental surgeries on enslaved women. And he was attempting to repair urogynecologic fistulas after childbirth. But the thing was, he did not use anesthesia, and there was no informed consent. And so this is kind of where that notion that Black women feel less pain. And there were 3 enslaved women that are mentioned that you can find in literature and even online that he performed multiple surgeries on, and one in particular he performed at least 30 procedures on. And so if you can just imagine. So the US government's role in sterilizing women of color is also astonishing. They call it eugenics, and that is the protection of society from offspring of those deemed dangerous, inferior, those who are poor and disabled, mentally ill, criminals, Black and Indigenous people of color. And so there's a history that has developed in African Americans, North Carolina, between 1929 and 1974, 7,600 women were sterilized. 85% of those women were women and girls, and 40% of those Black women. There was no consent. Puerto Ricans also, it's been reported that 1/3 of their women during that period of time were sterilized, tubal ligations, no consent or understanding of what was even taking place. Many times they were just whisked, maybe after an appendicitis, had an appendectomy, and then they were in there. And even US pharmacology or pharmaceutical companies that were doing experimental birth control trials on in the same group without proper consent. All of this to control their populations, control the race. And then there were even reports of Native Americans through the 1970s and 1980s, not so long ago, where the government had ordered sterilization at Indian health clinics. And 25% of these women ages 15 through 44, and again, no consent. So you can understand why many, especially minorities, may just have a level of distrust. And we know that these biases in healthcare lead to health disparities. And we know that disparities are basically the differences in health outcomes. And what does that mean? What is that? And what are the causes of among groups of people? And there can be differences in life and death, differences in the way certain diseases manifest in them. So let's take a look. We know that the health disparities, whether it's more hypertension in African Americans and cardiac disease, or prostate cancer and breast cancer, but you have to look past race and see what are those root causes. What are the social determinants of health that are affecting these populations, and it may be financial. Maybe they're unemployed. They don't have the resources to get their medications and take it on a regular basis. Maybe it's their environment and neighborhood. They don't have transportation, access to the clinic. Maybe they live in a very unstable or unsafe neighborhood, and even their zip code can be a social determinant of health based on where they live and opportunities and amenities provided there. Education, poor education, and the level of knowledge with regarding maybe their health care. Maybe they live in a food desert, or have an ongoing hunger of children going out without breakfast and other meals while the parent is working and left at home. We had a food desert even within Oklahoma City, within this region that our institution is upon. And just recently, the erection of Homeland Grocers is a first that will hopefully continue further developers within these underserved, marginalized communities. And then, of course, the social support, discrimination, stress, those things in particular are at a greater risk and are also can be root causes for some of the health issues that Black and brown people face. And maybe it's the provider, maybe there is a language barrier or the quality of health. All these things will determine the health outcomes of a person. And we know that structural racism is a public health crisis. Structural racism is the ways in which society is set up in such a way that advantages and opportunities are preferentially given to those of one race rather to another. And yes, structural racism leads to chronic stress, anxiety, heart disease. There was a study that looked at college students under stress, under chronic, repeated, everyday stress. And they measured the urinary catecholamines, the norepinephrines and epinephrines. And there was a marked increase in these levels. And so it is something to think about when an African or a Hispanic mother may fear for their child as they walk out the door, wondering if they're going to be able to come home, if they are stopped by law enforcement in their car. Will they live? Will they make it home? That chronic stress of being followed and watched in a grocery store or a convenience store, thinking that you're going to steal something, or crossing the street to the opposite side so that a person does not walk on the same side of someone that they feel appears quote unquote threatening. And so on a daily basis, this is affecting not only the psyche, but also the physical health of people of color. And so as we become a society that is becoming minority white as of in 2045, a census is projecting that will be the tipping point of 51% of people of color will outnumber whites 49.7%, and it will continue to rise. And this is a result mainly because of the Hispanic population increase and young ones, young people increasing, and less of the elderly people, they will be dying off, but we're having this explosion of young Hispanics. And so we know that African Americans are 30% more likely than non-Hispanic whites to die prematurely from heart disease. And African American men are twice as likely as whites to die prematurely from strokes. Native American and Native Alaskans have 2 times higher rate of infant mortality than non-Hispanic whites and high rate of smoking. So we have to also factor in within these races, what are the behaviors? What about the smoking? What about the alcoholism? And those issues. African American mothers also have a higher rate of infant mortality. And we know that African American females are twice as likely to die from breast cancer than white counterparts. So it's very stark. We, in general, compared to whites, all of these minority groups bear a disproportionate burden of all of these diseases that are listed regarding heart, obesity, hypertension, premature death, cancer, more injury, lower life expectancy and decreased quality of life, loss of economic opportunities, and perception of injustice. And so this is just showing you that compared to whites, Hispanics and African Americans comprise greater than 50% of uninsured, have poor health outcomes, have higher infant mortality, are more likely to go without a doctor visit in the last year, experience more bias, as we talked about, in prejudiced nature on the part of healthcare providers, have lower quality of care, and are underrepresented in medicine. And so we know to conclude that diversity improves patient care. They've shown that race concordant visits, when the doctor is of the same race as the patient, the visits were longer, they had a higher rate of satisfaction, and higher patient ratings were independent of a patient-centered communication. And these attitudes may mediate the relationship. So its recommendations are, it's important that we increase ethnic diversity among our physicians and healthcare providers, engender trust and comfort between patients and physicians of different race and ethnicity. It's important to develop that relationship so they can trust their provider no matter the ethnic background. So the key takeaways: diversity, the DEI, they are essential ingredients in making a multiculturalism environment the norm and not the exception. Biases in healthcare can negatively impact medical education, patient care, and research. Social determinants of health address the underlying causes of health disparities and resulting health outcomes in different groups of people. And also race concordance between patient and physician increases minority patient-physician trust. And so with that, I'm going to conclude, and hopefully you have gained a little better understanding of the challenges that we face within healthcare, education, patient care, research, and how we can better understand the aspects of health disparities and get down to the root causes of these issues and develop that center of trust and respect with our patients and with all people, no matter their backgrounds and no matter their circumstances. Thank you so much. All right, I think I have finished all through my time, but I think we might have time for maybe 1 or 2 questions. Justin?
Hi, Dr. Allen. I have no questions that have come through the chat as of yet.
Okay, I must have done an excellent job. But if you have further questions, please put them in the chat as you think about it. But this was just a segue. I didn't go into depth of how we can address these social determinants of health. How do we address these root causes so that we can bring health equity to our patients, and as well as within the medical education and reduce bias? We're going to discuss that at the end of today within our diversity champion in healthcare panel discussion. So you want to stay by because the answer is yet to come. Thank you.